Yeah, move on to the next slide. What I'm going to talk about this afternoon is what is known as the Liaison Psychiatry Pilot Service that my organisation, Birmingham Mind, are involved in. But before I do that, go to the next slide. Yeah, and I just wanted to say a little bit about Birmingham Mind and how we got involved in the Birmingham Changing Futures Together project programme. Birmingham Mind, as most of you hopefully will know, we're federated to National Mind, and in fact we're celebrating 60 years of Birmingham Mind this year. And we were involved in delivering a whole range of mental health services across Birmingham Mind. I'm not going to go into too much detail there, but I just wanted to make the point that over the last couple of years, we've become more and more involved in delivering crisis intervention services through our 24 helpline and our Talking Space Crisis Cafe services. The majority of our services, I think it's true to say, are have a strong element of prevention. And we've seen as an organisation significant growth over the last 5 years, about 40% growth. Now, our involvement with Birmingham Changing Futures Together was twofold, really. Firstly, we were a delivery partner, as you've seen, in the lead worker peer mentor service, which was an absolutely fabulous service to be involved in. But also, we were the lead delivery partner in every step of the way. This was the, if you like, the flagship of the supporting and developing and helping to develop the experts by experience part of this program. Thanks, Jan. So the Liaison Psychiatry pilot I'm going to talk about was a 6-month pilot. It was initially located at the Queen Elizabeth Hospital here in Birmingham, and it was funded using some underspends from our involvement with the lead worker peer mentor service back in 2019. And it was very much a collaborative partnership between our colleagues in the clinical commissioning group, colleagues within the Mental Health Trust, ourselves and our partners in the Birmingham Changing Futures Together programme. Thanks, Jan. What I'd like to do is just tell you a little bit about the background of the service and how it came about, what the aims and objectives were, a little bit about the role of the navigators that were seconded to this service for 6 months. Some brief data breakdown on referrals to the service, the kind of interventions that my colleagues in Birmingham Mind were involved in, some feedback from the pilot that we received, and then finally just a final slide on an update, as Jean mentioned earlier, that we've now developed this service much further. Thanks, Ian. So the lead worker peer mentor service, as a lot of us know, came to an end in June 2019. And through the work that had been done with our partners on the programme, particularly interviews and some of the statistics relating to individuals attending A&E, became very evident that this aspect of this particular model would, potentially be beneficial in an environment such as accident and emergency departments, to try and prevent inappropriate attendance at that department, as well as helping to navigate individuals that had attended had attended those individuals with multiple complex needs into more suitable solutions and services. So using that underspend from the lead worker peer mentor service, Birmingham Mind was able to second 2 colleagues as recovery navigators to work within a team within the Queen Elizabeth Hospital, which was initially known as the RAID team, which is Rapid Assessment Interface Discharge, which is now known as Liaison Psychiatry. And the pilot that we were involved in for 6 months started in January 2019, and was ended to coincide with the end of the lead worker peer mentor program in June of the same year. Thanks, Jan. So you will appreciate that 6 months is not a long time to undertake a pilot, but what we needed to do is just agree with our partners what the aims and objectives were for this service. And primarily we were looking at focusing our energies and efforts on supporting some of the key social and environmental determinants of poor mental health that were leading people to seek support within the accident and emergency departments. We wanted to assist in helping the reduction of diverted mental health admissions, and to support and assist with diverting individuals away from admission to hospital by providing, if you like, facilitating and navigating individuals to more appropriate services. And these included support around what we now know. We know more in terms of the catalysts of poor mental health that might include social crisis issues, risk of homelessness, isolation, disputes, rent arrears, poverty, domestic violence, to name but a few. Certainly quite a number of the people that we were seeing during this pilot were people who had multiple disadvantage, and particularly those with mental health distress and homelessness. So we also wanted to be able to give people the right advice on issues that are likely to include advice and signposting around mental health, homelessness and housing, substance use and recovery, and particularly I think a lot of work was done around welfare and housing benefits and debt advice. Thank you, Ian. And the role of the recovery navigators, again, we had to be very clear with our partners about what we could and what we couldn't do. And that was the main aspects of their role were to encourage and inspire and motivate people accessing urgent care, to promote their individual well-being, to support the patients in a timely manner, so developing those key relationships with statutory and non-statutory services, to work closely with what was then the RAID team in order to escalate crisis at the earliest opportunities. Also to be, to receive referrals from that team, and particularly identifying where we could alternatives to crisis attendance, and so that we could build robust pathways into other services and other agencies. Also to support alongside RAID the psychiatric decision units and place of safety services, and where we could other urgent care services, to maximise that kind of throughput of patients to the most appropriate support network. Thank you, Jan. So just a little bit about the this is just a very brief overview of some of the breakdown. In that 6 months period, we saw 137 individual patients or clients who accessed this service. So on average, we were seeing well over 20 new patients a month. And although initially the pilot was developed to meet the needs in the accident and emergency department, we also began to take referrals from inpatient wards, from the psychiatric decision units, and also the clinical decision unit. So you can see there was quite a mix of referral sources from within from within the hospital situation. Thanks, Jan. It was interesting to pick this point up. I wanted to put this into the slide. About 65% of those people that we met and supported were already known to either one or other of the secondary mental health services in Birmingham, i.e. the Birmingham and Solihull Mental Health Trust, or Forward Thinking Birmingham, as part of the Women and Children's Hospital here in Birmingham. So quite a number of, well, 65% were already known or had accessed mental health services. Whilst before they came to the QE accident and emergency department. Thank you, Jan. Some of the reasons why people were turning up, there were numerous reasons, and some of these individuals had multiple needs. So a lot of people were experiencing distress because of isolation and loneliness, a lack of kind of adequate community support for people. Debt and benefit advice was quite a high incidence of people with those kind of needs. Eviction or threat of eviction and homelessness, again, very high level of those referrals. Individuals who not only had potentially mental health problems, but also had alcohol and drug, needed alcohol and drug use support. Hoarding, also support to register with general practitioners. We also had quite a few referrals. I can't remember exactly how many that of individuals experiencing domestic violence. So that's not an exhaustive list, but to give you just a flavour of the types of need people were presenting with when they were coming into this service. Thanks, Ian. So what was happening before, you might argue, before this pilot? Well, prior to the recovery navigators being in place, the RAID, or the liaison psychiatry team, would generally conduct their initial mental health assessment for individuals, and if deemed suitable, the client would then be allowed to leave, i.e., they were not necessarily met kind of clinical caseload. And there are clearly pressures and priorities and staffing and workload, as well as a real lack of specialist knowledge of community-based support services. And this would frequently result in clients kind of leaving, attending A&E, having their assessment, leaving the hospital without being adequately signposted to the support they required, and that then in itself resulted in people revisiting the hospital. Thanks, Jen. So with this particular service, it added to the knowledge and dedicated time to ensure that patients were not allowed to leave the hospital without appropriate support in place. The kinds of interventions we were able to offer varied dependent on the reason for involvement. And also what varied was the length of time the recovery navigators would spend with individual clients or patients. And this would, again, vary dependent on their needs. So for some people, it was very a couple of light touch discussions, or it could take several weeks of contact with the client, follow-up, as well as numerous services with numerous other services that the individual was trying to access. So a kind of range of intervention and the amount of time that took to support people. Thanks, Jen. The kind of interventions that, just to give you a flavour of the kind of work that was being provided, offered. So we were the recovery navigators were actually physically located within the QE hospital for most of their time. We were liaising and negotiating with housing providers around accommodation, signposting to appropriate services, including services like floating support for individuals. Colleagues took individuals, patients to view properties and presented with them to neighbourhood offices. Some advocacy work on behalf of the clients, so they receive services they were entitled to. Even down to supporting individuals to create email addresses to enable ongoing sustainable communication with other services, help with and navigation around the benefit service, including universal credit, linking and liaising with GP practices, and also helping people to consider using other services such as crisis cafe services that were that certainly one of those crisis cafes in Birmingham, and also staff were able to accompany patients in person to food banks, clothing banks, shops, and also introductions to support services or other support services. Thanks, Jan. How are we doing? So, as I mentioned, this was a 6-month pilot, and as part of that, we wanted to get some feedback for the pilot to build into the evaluation for this service, and the feedback primarily was from the Mental Health Trust. And I won't go through all of this word by word, but certainly our colleagues, our clinical colleagues, found this service very, very helpful, very positive. There were some comments about the correlation between social deprivation, mental health issues, and subsequent crisis presentations at the clinical end, and a sense that the service genuinely seemed to provide support in an area where there was really a lack of knowledge and service provision. Medical staff would class clients as an emergency case if they believe them to be homeless without accommodation to leave to, even if their conditions weren't suitable to be classed as an emergency. So this inevitably for some people would result in the patient being able to stay at the hospital longer than was strictly necessary. So again, having the navigators accessible and on site certainly reduced the number of occasions medical staff had to resort to keeping people in hospital, and that was generally one of the ambitions or the objectives of this service, was to reduce that hospital admission by having navigators on hand on site. Thanks, Jan. So we had also some testimonials. We sought that out, and you can see a couple here. One from a registrar with the liaison psychiatry team, who spoke very highly of the service, and it said they were able to provide a brilliant platform to accelerate support and guide service users in matters that, if I'm honest, are not as accessible without them. Streamlining and promotion of our discharge planning process, and ensuring that there was follow-up in the community, and helping to prevent readmission. And also from one of the colleagues, there were a number of testimonials. I just picked out a couple. From one of the liaison nurses that we work with, again, positive feedback, and also there clearly remained a high need for the service, and would ease some additional pressures placed on both the acute hospital and the mental health staff. So that personal intervention around addressing needs in a holistic way. Now, the 6-month pilot finished. We had a lot of very good positive feedback, and you can see from some of the information I provided this afternoon that it was a very well appreciated service. What I haven't shared with you are some of the testimonials or feedback from beneficiaries, actually, and we had a lot of those. And we did an evaluation and presented this to senior managers within the Mental Health Trust, and they really loved the service. But at the time, they actually said, "We're really sorry, we have no funds for this service. Our idea was to prove the concept through this pilot, and hopefully get some money out of the Mental Health Trust to continue the service." So it was disappointing, frustrating at the time. So we stopped the navigation service as there was no funding. However, I am pleased to tell you that about 12 months ago, we were approached by the Mental Health Trust. My last slide, in fact, Jan, if you don't mind. And they asked us to develop this service further as a result of the success of the pilot. We now have a formal partnership with the Mental Health Trust, and further develop this type of intervention. And together, we've been able to develop the Recovery Navigator offer service, which is now based in 4 hospitals across Birmingham: the Good Hope, City Hospital, Heartlands, and the Queen Elizabeth Hospital in Birmingham, which is fully funded. Aims and objectives of the service have remained very much those that were identified as part of the original pilot. And recovery navigators employed by Birmingham Mind are now working very closely with our clinical colleagues within the liaison psychiatry team, doing exactly what we were doing during the pilot, and certainly delivering a range of very similar support interventions to address the social and environmental catalysts or determinants of poor mental health and homelessness. So I'm delighted to be able to say that, and this is really a consequence, a legacy of that imaginative collaborative approach in 2019, when we had the money, the underspends from the Lead Worker Peer Mentor Service to be able to do this pilot, and it's very much paid off. There you go. I think I've kept to time, but that's the presentation of liaison psychiatry. Thank you very much.
Thank you so much, John. Yeah, delighted to hear really how it's been implemented and something's really been mainstreamed that came from the programme. It's excellent news. Annie asked in the chat, but I think you already answered her question, because she asked if they were located in the A&E departments, and I assume from what you said that they are.
They are, yes.
They are. And,
yep,
and Annie would like to implement a similar service. I think Annie was from Bristol. So perhaps, I mean, you've got all that learning from the pilot to share.
Yes.
And sometimes areas want a pilot to prove something's going to work, but actually instead of more and more pilots, we need to be sharing that learning, don't we?
Yeah.
So perhaps we can put you in touch with Annie.
Absolutely.
And share that learning to try and help support what they're trying to develop over there. And Natalie said it's fantastic news, John. I know Natalie was involved at the time.
She was.
And well done to you and the team. Does anybody have any other questions before we move on? That was very comprehensive, John, so thank you for that.
Thank you.
Hi, Sean. Again, just to let you know that the full report, the evaluation report from the pilot, again, is on the Changing Futures Together website. So again, just as a starting point, might just be good if anybody's interested in that to have a look through that and maybe use it within their areas again. Obviously John will then be able to give a lot more detail, but as a starting point, again, I would definitely say go to the website. It's on there.
Thank you.
Excellent. Thank you, Jan. Annie has put her hand up. If you'd like to come in, Annie, if somebody can unmute her microphone, please.
Yeah, John, thank you. Again, I don't know, this is my dream to do something like this for very personal reasons, as well as just realizing it's important. I think it's incredible. I think it's fantastic. It's come out of just, you had a bit of money left. What should we do? That is really inspirational. Also, did you find it was, because there's also concern about from my point of view, for people attending A&E, maybe under the influence of alcohol or drugs, being taken by one emergency service, paramedics, but then being kicked out by the police. So, I mean, did you find that those situations were also there was a good intervention, because there was someone there to support them? Because this has happened to a friend and to people that I'm supporting, and it absolutely outrages me that this can happen.
Yeah. No, I do know of a number of occasions where that was the case, and we were able to stay with people and support them. I mean, I think it was interesting that some of the reasons given by people for turning up at A&E was simply they had nowhere else to go. And they couldn't get hold of GPs, or GPs were advising them to go to A&E, and this was just causing chaos, really. So being present, I think having that presence and building up those relationships with our clinical colleagues and patients was very, very important. Certainly we had a number of occasions where we were supporting people who were under the influence of alcohol. Challenging, difficult at times, but you will note from the presentation we were able to also though we were based in the QE hospital, we also did quite a lot of follow-up work with people, just to make sure that they were actually getting the support that had been identified. So yeah, it's a lot of hard work by those two colleagues, and I'm sorry they're not here to kind of share that with me.
Yeah, I'm so impressed. This was another thing that just came up on the agenda, and I thought, wow, this again as well. It's just, I'm really, yeah. And as someone with lived experience, you know, supporting friends, my own experience, you know, I just this and the peer mentoring thing to me just seems so valuable and important. And I cut my hat off to you for getting 4 hospitals now.
Yeah, well, we've done a lot of work, and I dare say some of that is about, if you don't mind me saying, educating our clinical partners about what's out there, what's available, how people can make best use of those agencies and organisations in the community.
Thank you. We've
You're
got
welcome.
another hand up. I think it's Thesis. I apologise if I haven't pronounced that properly. If somebody could unmute.
Yeah, is it Thesis? She
yes. I think that she's still muted by us. Oh, here we go. Excellent.
She actually works for Birmingham Mind. Oh, and
Hi.
here, right here. This is interesting. If we have time, Donna Henderson, Thesis. Donna Henderson was actually one of the recovery navigators. So delighted to see Donna here to hear the presentation. And Thesis.
We do have a couple of minutes. If either of you wanted to say anything, please do.
You're on mute, I think, Thesis, Donna.
Unfortunately, we can't hear you at the moment. Doesn't look like you're on mute, though.
I think just marginally too far away from the microphone, probably, of the computer with the camera on it.
Are you able to get a little bit closer to your microphone? No, I think that no. Oh, that's a shame. If you want to type into the chat, Thesis, if you wanted to add something, or Donna, but welcome and thank you for joining us today, and well done on how far the program's gone. I think we'll have to move on, unfortunately, but thank you so much. Thanks a lot, John.
You're welcome. Thank you.
I don't think that we've got more questions in the chat. We've got the report, so that's great. Lots of praise again. Excellent. And okay, we'll move on now. But thanks a lot, John, for your time. Really appreciate it.